Okay, good morning and good night, my friends. I'm Pang Yun Chou, PY. Thank you for your participation in today's webinar. In October, we organized two pre-progress programs of the Chang Forum in order to warm up the main conference in November. Because of the OGS is the main theme this year, so these two webinars will focus on dealing with the secondary OGS, respectively by Dr. Watanabe today and Dr. Choi next week. The two programs will be paneled by some experienced OGS surgeons in the discussion session. Today, we are so happy to have Dr. Watanabe with us. I had several times to catch up with Dr. Watanabe in international conferences before the COVID. Last time we met in Paris for the ISCFS. He is a famous as a surgeon with an experience for difficult cases in Tokyo, even in Japan. The topic he will present is how to deal with the secondary and the revisional OGS. By the way, four panelists are Dr. Clementine, Dr. Ellen Yang, Dr. Rafael Dinadai, and Dr. Dex Pascasio. So I can't wait to start. So Dr. Watanabe, please.
Can you my slide?
Yes, okay. I can see. Thank you.
Okay,
everything is good.
Okay. Sorry. Sorry.
No problem. Take time.
Okay.
Yeah. Thank you.
Okay. So good evening, ladies and gentlemen. Dear colleagues, my name is Yorkas Watanabe from Department Plastic and Reconstructive Aesthetic Surgery at Tokyo Metropolitan Police Hospital, Japan. This is a great honor opportunity for me to share my experiences with you in the 26th ICC's webinar. I really appreciate Professor Dr. Yurei Chang for organizing this webinar in this COVID pandemic. I really appreciate Dr. Cho for inviting to this webinar. I also really appreciate Professor Dr. Ring and other professors as panelists. Today, I would present my experiences about secondary and revisional orthodontic surgery. Prevention is the best treatment. This statement is common sense in the medicine. Prevention is the best treatment for the best results of orthodontic surgery, OGS. Today, my presentation consists of three parts. First part is to introduce face-first OGS concept I learned from your hospital. Second is introduce my consistent OGS procedure for primary, secondary, and revision cases. Last part is case presentation. first part is to introduce the face-first OGS concept for preventing the failure of OGS. My unit is plastic and aesthetic surgery, specialized in craniofacial surgery. And so our OGS approach is face-first approach. Face-first approach is to improve facial aesthetics and function as early as possible. This is also called aesthetic first, which most of patients desire. Face-first approach is also to minimize pre-orthodontic treatment. This is called surgery first, surgery early approach. Recently, I am focusing more on optimizing the surgical timing to minimize overall orthodontic treatment period. We call it surgery optimization approach. Face-first OGS aims to improve the harmonized facial aesthetics, including good occlusion and good smile. Face-first OGS is mostly based on double jaw, two-jaw OGS. Why do we choose two-jaw OGS for facial surgery? First purpose is to acquire a good occlusion combined with orthodontic treatment. Good aligned occlusion is important not only in function, but also in facial aesthetics. Second purpose is to acquire the harmonized facial aesthetics. It is important to acquire static facial aesthetics. Recently, the number of revision cases operated in other clinics is increasing in my clinics. Most of cases are overtreated, overshortened, ignored, and destroy the patient's nature. Preservation rhinoplasty, as all of you know, has been popularized in reducing rhinoplasty for Caucasians, especially because of previous many complications regarding reduction procedures like hump reduction. Surgeons have come back to the basics and preserved anatomical structures and respected patient's nature as much as they could. I would like to propose the same concept can be applied to OGS. Most of OGS for Asians are reduction OGS, like mandibular prognathism, bimacular protrusion with gummy smile, and so on. In my opinion, preservation OGS is one of the important concepts to make the harmonized facial aesthetics. She is a typical skeletal class 3 case treated by two-jaw OGS with clockwise rotation. She is a long face case with retruded chin treated by two-jaw OGS with counterclockwise rotation and genioplasty. This patient is a case with protruding mouth and retruded chin. She was treated by two-jaw OGS with counterclockwise rotation and genioplasty. She is a left crest case with severe asymmetry and class 3 malocclusion. She was treated by two-jaw OGS with clockwise rotation and genioplasty. She is a facial asymmetric case due to the right side of the hemimandibular hyperplasia. She was treated by two-jaw OGS with roll pitch and yaw rotation and simultaneously mandibular contouring surgery. Third purpose is to acquire a good smile. Smile is a dynamic facial aesthetics and the most important facial expressions. This patient was a facial asymmetry case with asymmetrical gummy smile and treated by two-jaw OGS. This patient complained about the negative gummy smile due to past OGS elsewhere by other or maxillofacial unit. She was treated by revisional two-jaw OGS with clockwise rotation using bone graft and genioplasty. This patient has anterior open bite with maxillary protrusion treated by two-jaw OGS combined with coil and Wasserman procedure. This patient has anterior open bite. Second is to introduce my consistent OGS procedure for primary, secondary, and revision cases. My procedure is based on face-first concept to correct the facial skeleton using 3D computer simulation by surgeon, two-jaw surgery, and single spring technique. Single spring technique, as all of you know, gives surgeons freedom for aesthetics and skeletal adjustment for individual soft tissue and envelope, especially in case of complex facial asymmetry. In the planning, CT diagram data and the dental data are imported into 3D simulation software. 3D computer-assisted surgical simulation cast is determined based on clinical facial appearance, skin envelope, soft tissue, upper ancestral jaw, nasal morphology, and position, and orbital eye position. And above all, surgeons must listen to patients' desire, request, and expectation. In initial treatment stage, patient and surgeons must share the same treatment goal. How to transfer 3D planning to real patient's facial skeleton on the surgical table. In this step, the problem is this. Nowadays, the surgical double sprint printed out by CAD/CAM technology are popular to do this. But in complicated secondary and revisional cases, these techniques are not suitable based on my personal experience. My procedure is very simple. Direct measurement method. It is a simple way, just drawing a osteotomy line on the patient's facial skeleton. I used 4 points as standard. 2 points are inner standard point from ANS to piriform. Other 2 points are bilateral outer standard, measured from the gum of the first molar along the zygomatic buttress. I'd like to share my short video. To direct measurement method, we use the caliper and transfer the 3D planning on the real patient maxilla. Then the bone is cut precisely near the standard point, I use piezoelectric devices. In some patients with thin maxillary bone, piezo is very useful to reject the bone precisely, especially the lateral side of the maxilla. The bone is very thin, so we must take care about the osteotomy. Remove the very thin parts of the lateral maxilla. Then after disjunction, bone removal around descending palatine artery and pterygomaxillary junction using piezoelectric devices. The yellow area are bleeding area, but unfavorable to clockwise or impaction area. Using piezoelectric devices, you can easily remove the bone around the descending palatine artery. This part of the bone resection is mandated to clockwise rotation or setback and impaction for especially the aesthetic cases. So before making the maxillomandibular complex, the rufo-1 segment is moved to the planned position and 3D cast and fixed temporarily with microspray plates, which are easily bended compared to mini plates. Especially for the revisional cases, this temporary technique is very useful. The occlusion is guided by the final occlusal splint with temporary intermaxillary fixation first during surgery, and then we checked several checkpoints are examined to ensure the best facial symmetry and profile with consideration of the skin envelope and soft tissue. As all of you know, this is the intraoperative evaluation and checkpoints in soft tissue proposed by Professor Chang. Anteroposterior sagittal positioning of the maxilla is adjusted to provide optimal mid-face projection and paranasal contour. The anteroposterior sagittal relationship of the mandible to the maxilla is controlled by altering the maxillary pitch by clockwise or counterclockwise rotation. In sometimes, the MMC position is changed and adjusted to improve soft tissue balance by surgeon's evaluation, especially in facial asymmetry cases. It is because 3D cast has the limits of predictability of soft tissue movement. OGS is not only for improvement of occlusion and airway, but also for improvement of facial aesthetics. These three factors are trinity of OGS. Last part is case presentation. Today I have 5 cases. There are several major causes of secondary and revision OGS. First is post-operative complications related to infection and fracture. Second is design and planning failure. Even if we are planning by 3D cast, we may encounter this failure in case we cannot to extract patient desire and reflect patient's preference. In the near future, this kind of failure will be solved by AI application to planning software. Third is technical failure. At the last is related to patient-specific and personality. The last cause is very difficult to avoid in advance in some cases. In this time-limited presentation, I would like to focus on desire planning failure and technical failure. Case one is design and planning failure. A 27-year-old female came to my clinics for revision orthodontic surgery. She had already a single jaw surgery, SSRO, and orthodontic treatment elsewhere 5 years ago. Her occlusion was well aligned and stable. What is your treatment plan for her?
So Dr. Watanabe, are you asking for the audience?
Okay, just joking.
Okay, thank you.
Okay. Very time limited, so sorry. Her chief complaints were mouth protrusion, especially mandibular protrusion, downward of oral commissure, facial asymmetry, long face, and mid-facial depression. Her complaints were not completely solved except malocclusion after the previous treatment. This is a typical case of mandibular prognosis treated by a single jaw surgery. This is pre-op CT showing screws and plates left on the mandible. The former procedure was SSRO with genioplasty. To solve all of her complaints, I plan surgery-only approach, 2-jaw OGS with clockwise rotation, genioplasty, and mandibular contouring surgery. To solve her complaints, 2-jaw clockwise rotation was planned on this slide shows. Posterior impaction of the maxilla was planned by 3 mm. In this plan, point A was set back by 2 mm. Upon one tip was set back by 3.4 mm. Ogonium was set back by 6.8 mm before genioplasty. Mandibular alveolar nerves were traced to avoid injury during mandibular contouring surgery at the same time. Based on this, cutting lines were designed meticulously. In this case, I plan to change A and B indicator of maxillomandibular AP relationship from 1 degree before surgery to around 3 degrees after surgery. During surgery, soft tissue improvement based on 3D cast was evaluated and confirmed. Profile was changed from concave and convex type. Oral commissure changed from downward to upward. Minor facial symmetry was corrected. This is a typical result of patient with mandibular prognatism treated by two-jaw counterclockwise rotation. Lateral cephalogram shows MMC was clockwise rotated to move in the planned position. She also acquired a good upward arc smile. Of course, even in this surgery-only case, skilled orthodontists had managed her occlusion not to be changed for about 6 months after surgery. This is showing heat map of facial volume changes before and after treatment. By two-jaw clockwise rotation, her nasal depression has been improved without the maxillary advancement. This phenomenon is very important consideration to plan the maxillary position, particularly in mandibular prognatism with mid-facial depression. I always take several points into consideration in designing for favorable result in mandibular prognatism and skeletal class 3. OGS is not to move MMC to the average position. The maxillary is advanced, in my experience, within 2 millimeters to avoid nasal deformity. A and B is a benchmark set between around 2 and 4 degrees. Change in profile by clockwise rotation of MMC. Care for nasal morphology to prevent nasal deformity. Consider age, gender, teeth showing, smile, soft tissue envelope, and total facial balance. Case 2 is a design and planning favor. A 46-year-old female came to my clinics for revision OGS. She had already a single jaw surgery, SSRO, and orthodontic treatment elsewhere when she was 30 years old. Her occlusion was well aligned and stable. What is your treatment plan for her? Her chief complaints were facial asymmetry of oral commissure. Her complaints were also not completely solved except malocclusion after the treatment. On smiling, occlusal count, asymmetric commissure were more evident, bothered and hesitate her to smile for her life. This is a typical case of facial asymmetry with malocclusion treated by a single jaw surgery. This is pre-op CT showing mild facial asymmetry. The left side of the maxilla height was 2 millimeters longer than the right. And also the left side of the mandible was bigger than the right. To solve all of her complaints, I planned the surgery-only approach, two-jaw OGS with low rotation and mandibular surgery on the left side. I also proposed facelift and fat grafting after 6 months of two-jaw OGS to get better result for her age. This is 3D planning. The maxilla was moved to the right side by 2.5 millimeters. The right side was elongated by 1 millimeter. Left side was shortened by 1 millimeter. The right The left side of the mandible cutting line were designed precisely and meticulously. I plan to make the face symmetry as much as I could on the facial skeleton. Facial asymmetry was improved, except skin laxity on the left side, as I suggested her before surgery. She also acquired a good symmetric smile. This pre and post-op facial symmetry was corrected. From the lateral view, moderate sagging around the neck was noticed after OGS. Lateral cephalogram showed MMC was moved in the planned position. After 10 months, I performed a deep frame facelift and neck lift, fat injection, and liposuction around the neck to get better result of OGS. This is pre-op and final result. A desire for the treatment was not just only to acquire facial asymmetry, but also to improve facial rejuvenation. In secondary and revision OGS, it is important to plan the skeletal position meticulously. In addition, soft tissue treatment after OGS is important as well to get a better result. Patient will be happier to have balanced treatment on both sides of facial bone and soft tissue. Case 3 is a disastrous failure. A 27-year-old male came to my clinics for revision OGS. He had already 3 times of 2-jaw OGS with 10 millimeter impaction of the maxilla for small face during past only 6 months in other cosmetic clinics. His chief complaints were over-shortened, much of skin sagging around the lower face. His occlusion was aligned and stable at a glance, but the center was shifted to the right by 4 millimeter. There was the wire sticking out in the center of the mandible. He also complained about the limitation of mouth opening, maximum 15 millimeter, and difficulty in biting because the maxilla was like floating. This is pre-op CT showing no plates on the maxilla and the mandible after just 2 months of the last 2-jaw OGS. The bilateral mandible displaced anteriorly. The pre-op CT explains everything of his complaints. What is your treatment plan for him? To solve all of his complaints, I plan 2-jaw OGS with iliac bone graft. This is really planning. The maxilla was planned to elongate by nearly 5 millimeter. The bilateral mandibular were planned to be repositioned with coronoid process osteotomy because of contracture of the temporal muscle. Intraoperatively, the maxilla was not fixed and not unioned like floating. It was very difficult to move the maxilla to the planned position due to severe contracture around the PMJ after 3 times of 2-jaw OGS. The blood supply to the maxilla was the maximum priority in this kind of multiple revision case with this severe contracture. After all aspects of facial balance were restored, the MMC was finally fixed with multiple bone grafts from the iliac crest. The bilateral mandibles were positioned and fixed with coronoid process osteotomy. Post-operative course was uneventful. The post-op CT showed the maxilla and the mandible were repositioned without relapse. Grafted bones healed well. This is pre-op and final result after 12 months after surgery. He restored his smile, stable occlusion, and mastication. Skin sagging around the lower face was improved. He also restored his self-esteem after the surgery. This case is a disastrous and hard case, but careful 3D planning and basic procedure made it possible to resolve his chief complaints and save his social life. Case 4 is a design planning failure and technical failure. Revision cases of 2 jaw OGS from OMS are referred to our unit. The number of these cases are increasing because patients desire not only stable occlusion, but also facial aesthetics. She had 2 jaw OGS by OMS as well for the treatment of skeletal class 2. Her chief complaints were protrusion around the mouth, over shortened face, asymmetry of oral commissure, and difficulty in teeth showing on smiling. Her occlusion was under postoperative orthodontic treatment. This is pre-op CT. What is your treatment plan for her? In frontal view, I plan to elongate the lower face length, improve smile arc, upper incisive jaw, and facial symmetry. In profile view, I plan to elongate lower facial lengths, improve oral protrusion, and acquire E-line. To solve all of her complaints, I planned 2 jaw OGS clockwise rotation with bone grafting. To improve her profile, 2 jaw counterclockwise rotation, MMC setback by 2 mm and 3 mm elongation was planned. This is a superimposition pre-op CT and 3D cast to check the right position of the MMC or not. During operation, temporary fixation with microplates and screws was very useful to adjust MMC to soft tissue envelope. Especially in this kind of floating position of the maxill is very useful. After checking all aspects of facial balance, the MMC was finally fixed using mini plates. With multiple bone grafts from inner cortex of the mandible. After 1 year, she had well-balanced facial lengths and facial symmetry. In profile view, her overall protrusion was improved. Now she acquired nice E-line. She finally acquired nice and symmetrical smile arc. Case 5 is a last case, design, planning, failure, and technical failure. She had 2 jaw OGS by PRS elsewhere. for the mandibular prognatism 6 months ago. Her chief complaints were protrusion of the maxilla and around the mouth, shortened chin, and nasal deformity after OGS. She also complained about asymmetrical of gummy smile. Her occlusion was under postoperative orthodontic treatment. The left side is pre-op her original face. The right side is 6 months after OGS at the other hospital. The left side is much better in facial aesthetics, in my opinion. Before surgery, she had just a minor mandibular prognatism. It is difficult to understand the previous surgical planning. There are some reasons behind this tragic result. This is pre-op CT. What is the treatment plan? To solve all of her complaints, I planned 2 jaw OGS, clockwise rotation, and genioplasty with bone grafting. I also propose revisional rhinoplasty after 6 months of 2 jaw OGS to get better result. In this kind of case, it is useful to refer the original CT. The left side is her original CT. I planned the maxillary position while referring to the original one. I planned the maxillary shortening by 2.5 millimeters, setback by 4 millimeters, and clockwise rotation. For the genioplasty, I plan to elongate the shortened chin by 3.5 millimeters with bone graft from the inner cortex of the mandible. This is a superimposition of original CT and 3D cast. Intraoperative findings. The maxilla was advanced by 3.5 millimeters by the previous surgeon. After checking all aspects of the facial balance, the MMC was finally fixed using mini plates. For the genioplasty, the chin was elongated by 3.5 millimeters with bone graft from inner cortex of the mandible. After 1 year, she had well-balanced facial length and facial asymmetry. In profile view, her oral protrusion was improved. Now she acquired a nice E-line. She finally acquired a symmetrical smile arc. She also restored her self-esteem after the surgery. After 1 year, I performed revisional rhinoplasty using postchondral graft to get better result of OGS. In secondary and revision OGS, it is important to care for the nasal deformity. Rhinoplasty improved the result of OGS in case it is planned. Respect patient's nature. So in conclusion, the key to success are 3D computer simulation, sharing the same goal with the patient, evaluation of pre- and intraoperative soft tissue, and close communication with skilled orthodontist, and finally, respect patient's anatomy and nature. Even among them, respecting patient's anatomy and nature is important to prevent the disaster result in OGS and facial bone contouring surgery as well. Preservation OGS is coming new concept. Thank you for your kind attention.
Okay, thank you. Thank you, Dr. Watanabe. Yeah, I am so learning a lot from your sharing your experience for the 5 cases. I think all the 5 cases, you are ready to receive lots of questions from the audience. And every case, I believe it could attract so much hard discussion in this section. Thank you very much. Yeah, so good a presentation you give us. Okay, I think we are invited today is our panelist to give some comment for Dr. Watanabe. So I think in the first, we are invited Professor Clement Lin. Yes. So hello, Clement.
Hi.
Thank you.
Hi, Dr. Watanabe.
Hi.
Long time no see.
Yes, I miss you.
Yeah. I'm so pleased to see your presentation here, and we can see that you are not only the expert of OGS, but also you did a great job in the rhinoplasty and everything. So, so we learned a lot from your lecture. That I think the first priority is to use the 3D simulation and planning for those patients coming for revisional surgery. And so I believe there would be some difficulty for everyone, that when we see those patients, we see from the face, and that's for soft tissue part. And when we planning, we do the skeletal and dental part. So how can we generate those numbers? I mean, from the soft tissue discrepancy or soft tissue problems, and then we convert those data, what we see in the clinic, and then we can generate the skeletal movement. That would be my question for you.
Okay, thank you very much for your question. Yes, this kind of determination is very difficult, especially for the revisional and secondary cases, because the many problems are gathered in face. So if we could get the regional CT data and regional photo from the previous hospital or from the patient, they were very useful to plan the skeletal 3D planning. So how about you, Dr. I'd like to ask the experts, Dr. Professor Rin. So every case is very different. So
I don't have much experience in doing the secondary surgery from other places. But in my experience, I have some that even after the 3D planning, we have to shift to single splint technique during our surgery. Maybe because of the facial symmetry or other problems. That's our experience. But usually we have to prepare for this kind of situation happening during the surgery. So and commonly we do have some feeling, especially when patient has some asymmetry that is from different aspects. For example, patient with ocular canting, the eyes are canting, the nose are deviated, and for those patients, they tend to have some deviated or habitual position of their natural head position. But using that natural head positioning could result in some difficulty when we go to surgery, because during the surgery, the patient are under anesthesia. So with the muscle relaxed, the head position could be totally different from when the patient are awake. So so sometimes we still have some considerations about using how to balance using the natural head position or just using the intrinsic landmarks. Maybe sometimes we have to find out a balance point. And I totally agree with you that the AI assistance may be the future resolution, and especially when we accumulate more and more data, and then we can see how the soft tissue will respond to the skeletal movement. Then we can try to achieve the more detailed modification for our patients.
Yes, I agree.
Yeah.
Thank you.
Okay.
Yes.
Thank you, Dr. Clement. And I will invite Dr. Alan. Yeah, please, Alan. Would you like to
Hi.
comment? Thank you.
Hi, Dr. Watanabe. Thank you very much for your excellent presentation. And I'm happy for the patients that they have you as the surgeon to rescue their botched primary surgery. So I'm just curious, from your experience, what is the most common chief complaint of these patients that come to you for secondary surgery? And when and for these secondary OGS, are there any special things to consider during the design and execution of the surgery? Also, I'm just because I really don't have any experience in managing or treating patients with that comes for secondary OGS. How would you manage their expectation of the surgery? Thank you.
Thank you very much. It's very difficult to know the patient expectation, especially for the secondary cases. So we try to communicate with the patient at least 3 times outpatient. So in Japan, many secondary and revision patients have they planned their own planning, bring to me. So
yes,
is relatively easily to know their expectation for the surgery. So sometimes some patient brings their desirable model actress, and they are very curious about the result of the next surgery. So I'm very nervous when do the surgery and planning the surgery, planning the secondary cases. So it's very difficult, and most of cases are very complicated cases in my clinic. So each cases we have to consider many things. So popularization is very difficult for the secondary cases. So
I see.
Yes.
Okay. Yeah. So how frequently Dr. Watanabe have the secondary cases in average in a month? Could you tell us?
Yes. Recently, mm, 1 or 2 cases.
Okay.
Yes, yes.
Yeah,
Very
great.
minor cases. I presented case number 1 and case 1 and case 2 is very a relatively simple case.
Yeah.
And case 3 is very disastrous cases.
Yeah, sure.
Yes, so in Japan, many doctors, many backgrounds to
Yes.
the cosmetic surgery. Yes, so that's a very big problem in Japan.
Understood.
So yes, so the number of cases, very disastrous case, operated on the cosmetic surgery, not trained in the OGS. So very terrible case.
Yes.
Sometimes come to my occupation
Clinic. Okay, so let's proceed to our next panelist is the Dr. Rafael Dinadai. Hello, Rafael. Yeah, thank you. Would you come in? Yes.
Thank you, Dr. Watanabe, for your very nice presentation. I have 2 comments. Thinking about the prevention of secondary OGS, how about your opinion about bone grafting in primary cases? And I also would like you to comment some tips for cleft OGS, please.
Yes, thank you for comments. First, bone grafting. Yes, in most of the secondary cases, I use the bone graft because the bone around the osteotomy line is very fragile. So to prevent the relapse, so we have to bone graft to strengthen the buttress structure. So secondary cases, most I use the bone graft, especially for the maxilla. So sometimes I use the bone graft for the primary case, like cleft cases, hemifacial cases. Yes, we do a lot of the bone grafting for those patients. So regarding the cleft case, yes, cleft cases. Okay, so Dr. Rafael, could you ask me again more precisely your question? Sorry.
Yeah, you already talked about maybe for cleft caves you have a different approach in primary OGS to prevent the secondary OGS?
No, the most of cases I do not. I usually use the same approach for the primary cases, secondary cases. Yes, I do always the same approach all of the cases. Yes, of course, I do the same approach for the cleft cases. So of course, we must take care for some consideration for the cleft cases or hemifacial cases, especially for the or occlusion cases. Yes, we have to take care for other aspects of the techniques. So.
Okay. Yeah. So for some congenital anomaly cases.
Yes.
Okay.
It's
yes.
very difficult.
Sure. Okay. Thank you, Rafael. And now that we welcome the Dr. Dex Pascasio. Yes, Dex, please.
Hi, good evening, everyone.
Yes.
Thank you, Dr. Watanabe, for a great lecture. And basically, I echo the comments of the doctors, the great doctors and panelists that asked their questions also. More or less, I had the same questions. But I think one of the things that I wanted to say or ask is that we all know that surgery is a detailed surgery, right? And even though it's a pre-planned surgery, meaning we had our simulations before, we prefabricated our splints, personally, in doing OGS surgery, I think it's also important that we listen to our what I call our intraoperative conscience. Like, for example, after you fixed all the plates, you followed your preoperative plan, you put on your splint, and then after seeing everything, you see that something's off. Like as what Professor Clement Lin said, we planned for the skeletal movement, but sometimes the soft tissue movement is not what we expected. And as surgeons, we're not only concerned about the occlusion, but of course, we also look at the aesthetic result. So in most surgeries, when this happens, I think we should be able to deviate from our plan. And if that would mean that we have to forgo the splint and do it freehand, then so be it. My question is, have you had cases like this for secondary surgery? Or is it the same concept? Can we do this such thing, or is it too difficult to do this in secondary OGS surgery?
Yes, thank you for your comment and question. So my every cases I use it only one single sprint final sprint for determine the MMC, and the position of the MMC planned on the 3D cast previously. And during the operation, first I decided the MMC according to the 3D cast and check the everything and facial aesthetics during the operation table. So sometimes, and especially for the asymmetry case, sometimes we changed the 3D cast during the operation to fit the best soft tissue. So is that the answer for you?
Yeah, for sure. No, because I was just wondering, because I know, I mean, in primary cases, it's difficult enough to do it freehand. I can only imagine how difficult it is to do it during secondary cases. Thank you, Dr. Watanabe.
Yes, I have cooperated the many orthodontists, and orthodontists have their own style. So some orthodontists made the sprint very thin, and other orthodontists very thick, and some other orthodontists made their sprints very soft. So I have to cooperate with many kinds of those orthodontists. Myself, I control my surgery by myself, not by orthodontist. So that's why I use the single sprint, final sprint during the surgery for the all cases. So it's very at first that kind of procedure is like very difficult or complicated, and but the practice is running with practice. So.
Okay, thank you, Dex. Yeah, now on we have some questions from the audience. The first is from So, Dr. So from Korea. He say, thank you for your presentation. For some cases, maybe the patient needs to elongate the maxilla. So you present a lot of a case using the bone grafting, right? So what else you have to maintain the stability after the surgery? Could you tell us? Yes.
Okay, thank you for question from Seoul. So bone graft, usually over 3 millimeter. I need to bone graft, I used the iliac crest. So within 3 millimeter, I used from the inner cortex of the mandible. So the cortex is very stable and strong to in my experiences, when I removed the plates and screws after around 1 year of the surgery, the bone is very well healed. And after operation, especially for the secondary cases with bone graft, first 3 weeks, I put the IMF band and stable and their occlusion. After 3 weeks, they slowly soft diet, and after 3 months, they can eat everything they want. So not too special care I usually do for the bone graft cases. But of course, we must care for the infection after the operation. So
Okay.
yes, but I never experienced the infection with bone graft for the maxilla. So it's very reliable procedure, I think.
Yes. Okay, for that cases, probably you will apply 2-2 plating for the fixation. Would you like to add any other plate for the bone graft?
Either.
Maybe here and here. Would you like to apply more plating for the bone graft?
Yes. For 4 plates for the mini plates to stabilize the maxilla, and 4 usually at least 4 microplates to microplates are used for the stabilize the bone graft. So around 8 plates on the maxilla when I use the bone graft.
Okay.
Maxilla.
Yeah. Okay. Next questions from Saron, from Philippines, Saron, and from Nobu in Japan as well. I think their problem is the same. They're asking, do you have any problems for old instrument removal in the secondary cases? Okay, the previous hardware you have to remove. So do you have any problem to remove the scrolling or the plating? And you show some cases the patient received transcortex, cutaneous scrolling. Do you have any problem to remove the scrolling? If you have, what is your solution? Thank you.
Yes. Very long screws for the mandibular fixation. Sometimes we encounter very difficult situation. So in such cases, I told the patient, if we could not remove the long screw from the mandible, I do change the SSRO to the vertical split osteotomy.
Okay.
So if the patient agree the change procedure during the surgery, I do the surgery. On the maxilla, most of the plates are easy to remove using the piezoelectric surgery around the plates. Yes, it's very easy when I use the piezoelectric surgery, because some plates cover the bone, but when we can use the piezoelectric surgery, minimum invasive procedure, I could remove the plates on the maxilla.
Okay.
But recently, I encountered the problems of the operated two-jaw surgery in foreign country, and they came to my country, and they asked me to redo the OGS. I did not do the what kind of screws used to for the patient. So last 2 months ago, such cases I happened. I prepared so many kinds of screw driver for everything, for nearly everything types of screws. But the screws had very tiny square. I encountered the first time, so I used the driver's head, changed it, and fit the screw. I made the driver by my colleagues during the surgery. So
Okay.
I get the all of screws and do the surgery smoothly after that.
Yeah, thank you, Dr. Watanabe. So later, I think invited Professor Low to give us some comment. Thank you, Professor Low.
Hi, Dr. Watanabe. Thank you very much for your presentation. I really enjoy your talk. I think you convey some message that for patients with difficult situation, secondary revision, after careful plan, careful execution of the surgery, and convince patient, even like second stage of soft tissue or nasal treatment, you can obtain a good result. I think tonight, I think including me, we all learn from you. Thank you.
Thank you very much.
Okay, thank you, Professor Low. Before I conclude these sections, I would like to invite all of our audience to show your face in front of the screen. And I think all the smile is all we care, not only in OGS, even in be an audience, okay? Yeah. Okay, I see our mentor, Professor Ray Chen is here. I would like to asking maybe Professor Chang will give us some comment too. Yes.
Thank you. I enjoy all the talk and all the discussion. I think we have a very good group, and we will learn from each other. And congratulations, Dr. Watanabe. You have very good patients to join with you. I hope that you can continue doing that and be an expert in the internationally. Thank you for your presentation.
Thank you very much, Dr. Professor.
Thank you, Professor Chen. So I will count to 3, and please give me your so sweet smile. Okay. Okay. 1, 2, cheese. Okay. Thank you very much. And for the next page. Yes. 1, 2, cheese. Okay. Yes. I collect all of your smile, so I will key all the smile into my AI data. Okay, thank you, Professor Watanabe. We are so enjoying for your talk and your presentation today. I have to announce our next topic. 7 days later will be presented by Dr. Bong Kyung Choi, Korea. Actually, I believe Dr. Choi is still remain in tonight online with us. The topic will very similar to the topic today. His presentation topic is the redo OGS, underlying causes, strategy, and outcome. So actually, these 2 programs, so-called pre-Congress programs of the Chang Forum, that's because we are welcome to our this year's Chang Forum 1 month later. Dr. Lin, would you like to say something to highlight our Chang Forum 2021? Yes. You have to demute it. Okay.
Turn on my microphone. Yes.
Yes, please.
This year is a very special moment that we could not meet each other, but I hope to see you on web, and hopefully we can see you next year. This year program is very concise, and because without of live surgery, many of our surgeons will incorporate our videos into our talks. So you can join our meeting and listen to the lecture, and at the same time, very instantly, we can see how the surgeons do the surgery. And you are welcome to raise your comments or questions just the same time. So welcome all of you to join our meeting. Thank you.
Okay, thank you, Clement. Thank you, Professor. So thank you, Dr. Watanabe again, and thank you our friend panelist, Dex, Rafael, Alan, Saul, Nobu. Yeah, thank you very much. Good morning and a good evening. See you 7 days later. Bye-bye.